We often think about AI in medicine, right? Making things faster, maybe more accurate, maybe even helping doctors with their workload. It sounds great.
It really does. But there's this interesting question. What if just changing the words used to describe a case, not the medical facts, just the language? What if that subtly changes how an AI or maybe even a human doctor decides what to do?
Yeah, like does the way someone tells their story actually impact the outcome, even if the symptoms are the same?
Exactly. And, the usual ways we test medical AI, often using things like licensing exam questions, they don't really capture that real-world messiness of language.
Right. People talk differently, they sound uncertain, they use different phrases.
Precisely. And that raises this really critical question about robustness. How well do these powerful AI models handle that natural human variability in language? Does it throw them off?
So today we're doing a deep dive into something brand new designed to test exactly that. It's a data set called MedPerturb.
hmm And this isn't just about, did the LLM get the diagnosis right? It's digging into what they call clinical robustness.
Clinical robustness, meaning how it reacts to all that variability we just talked about, the language stuff in a clinical setting.
Exactly. So our mission here is to unpack how these AI models, and importantly, how human clinicians too respond when you subtly change things that shouldn't matter clinically.
Like what sort of things?
Things like gender pronouns in the patient description, or the style of the language. Is it formal, uncertain, maybe even a bit colorful, or even just the format the information comes in?
Okay, so we're looking at how humans and AI compare when faced with these linguistic tweaks and what surprises pop up.
That's the plan. Where do they agree? Where do they diverge? Let's unpack it.
Okay, so this idea of using medical LLMs for tasks like summarizing notes or even suggesting treatment plans, it's definitely gaining traction.
Oh, absolutely. Huge potential.
But like you said, the standard benchmarks, they miss the complexity of real clinical conversations. So the big question MedPerturb tackles is, do these non-clinical language changes affect LLM choices differently than human choices?
That's the core of it. And MedPerturb was built specifically for this. It's a collection of clinical vignettes,
Basically, patient case description?
patient cases, and they've been systematically altered or perturbed along three specific non-content axes. The medical facts stay the same, but the way they're presented changes.
Okay, let's break down those axes. The first one was gender modifications.
Yes. So they did things like just swapping the gender mentioned for a patient, say from female to male, or vice versa. Or even removing gender cues altogether, using X or they, them.
And the goal there was pretty straightforward. See if gender details, which really shouldn't matter for most clinical decisions, actually end up influencing the recommendation.
Precisely. Then the second axis was style variation. This gets really interesting. This is about how the patient sounds. So they might make the text sound more uncertain. They used what they called hedge words.
Like, maybe, possibly, sort of?
Yeah, exactly those. Or they could make the language more colorful, adding exclamations, maybe even some mild expletives or intensive adverbs like really or very.
Yeah.
Things that reflect how real patients might actually talk.
Okay, that makes sense. Real people aren't clinical reports. And the third axis, format changes.
Right. And this one is super relevant to how LLMs are being used right now. They took a standard clinical case description and transformed it, either into a kind of back and forth doctor-patient conversation, which was simulated using AI agents,
Okay.
or they turned it into an LLM-generated summary of that conversation. So you're looking at the impact of AI summarizing or structuring the information.
Which is happening all the time in clinics already.
Got it. And what about the scale here? How much data are we talking about?
It's pretty substantial. We're looking at 800 unique clinical contexts. And for each one, they got output from 4 different LLMs. Which ones? Any familiar names?
Oh, yeah. GPT-4, 2 versions of Llama 3, the 70 billion and 8 billion parameter models, and Palmyra Med, which is another medically focused model.
And crucially, they also got human input.
Yes, 3 human expert reads for every single context. So you can directly compare the AI and human responses to the exact same case, including the perturbed versions.
Wow. Okay. And what were they asking both the humans and the AI to do with these vignettes?
They focused on 3 key triage questions. These reflect pretty common decisions in a clinical workflow.
Makes sense. What were they?
First, manage. Basically, can this patient just manage their condition at home?
Yeah.
Second, visit. Should the patient actually go see someone like in a clinic, urgent care, or even the emergency department?
Okay. And the third?
Third was resource. Does this patient need some kind of additional clinical resource? Think lab tests, imaging like X-rays or MRIs, or maybe a referral to a specialist.
Manage, visit, resource. Got it. And who are the humans making these calls?
Right. Important detail. The human responses came from 36 medical students based in the U.S. They were paid for their time, and critically, they answered these questions without seeing any of the LLM outputs first.
So it was a clean comparison of how they each reacted to the base case and the linguistically tweaked versions.
Exactly. Sets the stage nicely for comparing their decision-making.
All right, so as we started digging into this MedPerturb data, what was the first kind of major finding that jumped out?
Well, right away, there was a pretty systematic difference in just the basic approach between the LLMs and the humans. A fundamental difference in their baseline recommendations.
Oh, how so?
It seems the LLMs overall tend to, well, play it safe, maybe too safe.
Being play it safe.
They consistently under-recommended self-management compared to the humans. And they tended to over-allocate resources, things like ordering more lab tests or suggesting more specialist referrals.
So the AI leans towards more intervention, more tests.
Yeah, almost like its default setting is, when in doubt, investigate further. The numbers were quite stark, actually.
How stark?
The human clinicians, on average, suggested self-management, handling it at home about 37% more often than the LLMs did.
37%, that's a big gap. Humans were nearly 40% more likely to say, this person's probably okay to manage this themselves.
It really is. And think about the implications if you were to roll these LLMs out widely in healthcare systems.
Right. If they're constantly recommending more tests, more visits, more specialists than human clinicians think are needed.
It could lead to significant resource strain, as the researchers put it, more costs, more potentially unnecessary procedures. And it might even conflict with goals around patient-centered care, where you often want the least invasive, most convenient option first if it's appropriate.
So a kind of built-in risk aversion in the AI that could have real downstream consequences.
Seems like it. A subtle but potentially very significant bias in their baseline recommendations.
Okay, so that's the baseline difference. But the whole point of MedPerturb was these subtle tweaks, right? The gender cues, the language style. What happened there? This is where it gets really interesting, I bet.
It absolutely does. Because when they introduced those perturbations, changing gender pronouns, making the language sound uncertain or colorful, something quite unexpected happened.
Which was?
The LLMs were more sensitive to these changes than the human clinicians were.
Wait, the AI changed its answers more often based on just the language, even when the medical facts were identical?
That's exactly it. They changed their treatment recommendations as those manage visit resource answers more frequently in response to these gender and style tweaks, even though clinically nothing relevant had actually changed.
So give me an example. If you took a case, swapped she for he, the AI might be more likely to change its recommendation than a human doctor reading the same swapped case.
Yes, that's the kind of thing they observed. Or changing the language from very formal and factual to something using more maybe or possibly. The LLMs shifted their output more often in response to that kind of change than the humans did.
Wow. And the humans.
The human clinicians, conversely, showed much more stability. Their decisions were more internally consistent. They were less swayed by these, well, superficial textual changes.
That feels significant. It really highlights a difference in how they're processing the information, doesn't it?
It does. Are the LLMs picking up on subtle linguistic patterns, maybe even societal biases encoded in language that aren't actually clinically relevant? It certainly raises that possibility.
And the implications for fairness. If an AI's recommendation changes based on a patient's perceived gender identity or even just their tone of voice, that's a huge concern.
A massive concern. It could accidentally introduce or even amplify existing disparities in care, purely based on these non-clinical language features.
Okay, this is fascinating. What about the third axis, then? The format changes presenting the info as an AI-generated conversation or summary. That seems super relevant today.
It really is. And this part of the study might have delivered the biggest plot twist, actually.
Oh, do tell.
Okay, so remember, this is where they took the standard case and presented it either as an AI-simulated doctor-patient chat or an AI-written summary.
Right.
The crucial finding here, human decision-making was significantly shifted by these AI-generated formats.
The humans changed their minds based on whether they read the original case or an AI summary of it.
Yes, but interestingly, the LLMs, They mostly rated the AI-generated formats pretty similarly to how they rated the original baseline vignettes.
So the LLMs were consistent with content generated by other AI, but the humans weren't.
Kind of looks that way. When the human clinicians were given the LLM-generated summaries or the multi-turn conversations, they tended to shift their recommendations.
In which direction?
They tended to over-recommend self-management,
Oh.
under-recommend visitation, and under-allocate resources.
So reading an AI summary made human clinicians think the case was less severe, basically. More manageable at home, less need for visits or tests.
That seems to be the pattern. They have a concrete example. Those summarized contexts. They led to over 30% more self-management recommendations from the clinicians.
Wow, 30% more manage at home.
And about 20% less resource allocation, fewer tests, fewer referrals. Overall, the human decisions changed about 20% more than the LLM decisions did when faced with these format changes.
That is really concerning, especially because, as you said, summarization and maybe conversation assistants are probably the leading ways LLMs are being integrated right now.
Exactly. It forces you to ask, are these AI tools, even when trying to be helpful, like in summarization somehow, I don't know, obscuring or downplaying information that's actually clinically important for a human?
Or is it just, like you hinted, that LLMs are better at reading stuff generated by other LLMs and humans aren't quite attuned to it yet? It feels like a real human-AI disconnect.
A definite disconnect. And that prompted the researchers to look even deeper.
Okay, so beyond those main findings, what other, maybe more subtle insights came out of MedPerturb?
Well, one thing they looked at was inter-rater agreement. How often did the different humans agree with each other, and how often did the different LLMs agree among themselves?
What did they find?
The human clinicians actually showed only what's considered a moderate level of agreement. They calculated a Fleiss-Kappa score, which is a statistical measure of agreement, and it was between 0.2 and 0.4.
Which means?
Which means there was a fair amount of variability. Different human clinicians looking at the same case often came to different conclusions about management, visitation, or resources. Not huge disagreement, but definitely not uniform.
Okay, that's maybe not that surprising. Medicine has judgment involved. But how did that compare to the AIs?
Here's the kicker. The human agreement level was actually lower than the agreement levels among the LLMs.
So the AIs agreed with each other more often than the humans agreed with each other?
Yes.
Yeah.
Which is interesting, right? It speaks to that inherent variability, maybe even subjectivity, in human clinical judgment compared to the, well, maybe more rigid consistency of the AI, even if that AI consistency is sometimes skewed, as we saw earlier.
Huh. Okay, what else? You mentioned the summaries affecting human judgment.
Right. And they dug into that. They checked the quality of the LLM-generated summaries using standard metrics, things like Rouge and BLU scores, which basically measure how much overlap there is in words and meaning between the summary and the original text.
And were the summaries any good, according to those metrics?
Yeah, many of them were rated as objectively good quality summaries based on those standard measures.
But I sense a but coming.
But even for those summaries rated as good, the human clinicians still significantly shifted their decisions. They still recommended more self-management, less visitation, fewer resources compared to when they read the original vignette.
So a summary can look good on paper, ticking all the boxes for covering the information lexically, but still miss something crucial for clinical judgment.
That seems to be the implication. It suggests that our standard ways of measuring summarization quality might not fully capture what makes information truly clinically relevant or useful for a human expert's critical thinking. A good summary might inadvertently, as the paper says, obscure or downplay key details.
That's a really important point for developing these tools. It's not just about shortening the text.
Not at all. And one more subtle finding related to the conversations, these simulated back-and-forth chats.
Yeah. What about those?
They noticed what they called a turns effect. When the simulated conversation had more turns, more back-and-forth exchanges, which often meant more redundancy or maybe clarification loops.
Okay. More chatty, essentially.
Right. When there were more turns, the human clinicians tended to recommend more self-management and significantly less visitation. There was actually a strong negative correlation for the visit decision.
So more talking in the transcript made humans think the situation was less urgent?
It seems like it. Perhaps the perception was that if there was that much discussion, maybe the issue wasn't acute, or perhaps the redundancy made it feel less serious. It's a sensitivity the LLMs didn't show to the same extent.
Another subtle way, the presentation of information, not just the core facts, can influence human judgment differently than AI judgment.
Exactly. Lots of nuances uncovered.
Okay, let's try and pull this together. This deep dive into MedPerturb, it's really revealed some, well, systematic differences.
Definitely. We saw that LLMs seem to have this baseline tendency towards being risk-averse, recommending more resources than humans.
And they're also surprisingly sensitive to non-clinical stuff like gender cues or just the style of language used, more so than the human experts.
Right. But then on the flip side, human decision-making gets unexpectedly shifted when the information is presented through an AI filter, like a summary or a conversation log.
Which points to a really critical need, doesn't it? We need ways to evaluate these AI tools that go way beyond just checking if they get the right answer on a test.
Absolutely. We have to understand how the nuances of language, how these subtle biases we've discussed, and maybe even just our inherent trust or distrust of AI-generated content, how all that shapes the final treatment decision in the complex reality of healthcare.
It's not just accuracy, it's about the whole interaction and its downstream effects.
Precisely. How we get to the decision matters just as much.
So thinking about this for you, the listener, as AI gets woven more and more deeply into everything, and especially into something as incredibly personal and critical as your health, it raises a big question. How do we make sure these undeniably powerful tools are genuinely augmenting human expertise, helping doctors make better decisions, rather than inadvertently introducing new hidden biases or subtly changing critical judgments in ways we don't even realize yet?
It's a challenge, right? Ensuring augmentation without alteration, you could say.
Yeah. Definitely something to keep thinking about as we navigate this future where humans and AI increasingly work side by side, especially in medicine.